Hey y'all, welcome back. I'm really looking forward to spending some time with you discussing the topic of this video, which is a somewhat unique class of disorders. This is gender dysphoria. Uh, it has essentially one sort of disorder as its member. Boy, there is a lot, um, to unpack even in this relatively short class of disorders. What is here to unpack is related to the history of understanding gender within human developmental circles, sort of the science of gender and its relationship with mental health, and also socio-cultural phenomena, particularly politics currently, both in secular and religious settings. Um, so we'll get into all that a little bit in this video. There's also in the item for this class in this module a really well done documentary from Frontline about growing up trans that gets into these things in a fresh way as well. I'm also going to provide for you some resources that come from my own work, which I'll get into in just a little bit here. But I think if you're really interested in understanding gender dysphoria, what it looks like, what what it looks like to provide treatment, and the controversy about whether or not it even belongs in the DSM and defined as a disorder. I'm including my 172-page dissertation that I did my dissertation on a topic related to gender dysphoria, in particular, the decision-making process that parents go through when they are making decisions about giving informed consent for their children who are not of the age of majority. I mean, essentially, they're minors. They have to get consent for their children to undergo gender-confirming medical interventions. This is a topic that is near and dear to my heart. I think, as I've mentioned before in other videos, I grew up in the Deep South, in a part of suburban Atlanta that is known for its very conservative politics and conservative religious practices, particularly among Protestant Christianity. And I come from a Christian denomination that is known for sort of pathologizing stances when it comes to lesbian, gay, bisexual, transgender, and otherwise expansive issues. That being said, you may have noticed, a lot of you have noticed my Elvis lamp, but some of you also may have noticed the photograph just under Elvis right here. This is of my Uncle Swain. He was not trans, but was a gay man living in Atlanta. And I never got to meet him because he died by suicide in the 1960s. He was much older than my father. My father was, I think, 12 when he died. Of course, that stuck with me. And as I entered, when I was in your shoes, starting out in my master's program to become a mental health clinician, my intention was to go into this work to help, especially gay men, feel and deal with their reality, oftentimes as it related to or intersected with their spirituality. And so through that work, that was, I guess, in the aughts. So I was in my master's program between 2007, 2009. Learning about just elevated suicide rates and things of that nature. This is also not too long, maybe it was, I guess I graduated 15 years after homosexuality had been removed from the DSM-5 or DSM-4 TR. And which we'll get into. Gender dysphoria was in that manual as well as gender identity disorder. It was renamed in DSM-5 in 2013. And there have been a few small nuanced tweaks, more or less to the language that's been updated to the current edition, but the diagnostic criteria are more or less the same. But as I was doing work to understand the intersection of affectional orientation, also known as sexual orientation, mental health, and spirituality, and learning about the elevated suicide rates and suffering for particularly gay men, I learned that the suicide rates for people who identify as transgender and other forms of psychological suffering were even more elevated for people who identify as transgender. And so I also recognized at that time that the resources for mitigating that suffering were even more limited for transgender people. And so I sort of modified my practice to lean into that sort of gap in our mental health care system. So I have just a lot to share with you about gender dysphoria. And I think it starts with just some basic definitions. So you may already be aware of some of these things, but I want to cover them just to make sure. So it's important to recognize that even though they are often conflated, sex and gender are not currently considered to be the same thing. They're often conflated, I think, because culturally and practically, there are many ways in which they intersect. Okay. And more often than not, people who are born and assigned a sex at birth typically develop a sense of themselves and express themselves socially in ways that are associated with that sex. So people who are born and assigned male sexually oftentimes will express themselves in ways that are socially considered to be masculine, depending on the culture. And those who are born female will express themselves and have a sense of their internal world that is considered to be feminine by their culture. However, even our sense of sexuality is not as simple as perhaps we have been led to believe. So for our purposes, sex refers to a set of biological attributes in humans and animals. Okay, it's primarily associated with physical and physiological features, including chromosomes, gene expression, hormone levels and function, and reproductive and sexual anatomy. Excuse me. Sex is usually categorized, as I mentioned, as female or male, but it is important to note that there is variation in the biological attributes that comprise sex and how these attributes are expressed. As we talk, people talk about gender being sort of on a spectrum. But sexuality is too, right? It's just perhaps not as prevalent or as dominant in our understanding. Um, Oftentimes, people with intersex conditions, then maybe they are born with ambiguous genitalia or ambiguous chromosomes. Oftentimes, these differences are not visible. And they are often, because of the way our culture handles sexuality, they are often sort of hidden from view. And so there are assumptions that are made that are really not accurate on a wide and maybe even a deep level. So it's important to note that sexuality is not binary. It is not just male and female. And so gender, for our purposes, refers to the socially constructed, so that's different than the biological attribute. So socially constructed roles, behaviors, expressions, and identities of girls, women, boys, men, and other gender diverse people. So some people identify in ways that are not necessarily considered feminine or masculine. They don't identify as a girl, woman, boy, or man, and they are still are considered part of the wide range of gender diversity among human beings. So gender influences how people perceive themselves and each other, how they act and interact, and the distribution, this is very important, the distribution of power and resources in society. Gender identity is not confined to a binary, as in girl, woman, or boy, man, nor is it static. It exists along a continuum, or as I like to say, it's kind of prismatic, and it can change over time. By prismatic, I mean that you think about a prism. I'm imagining the album cover of Pink Floyd's Dark Side of the Moon, right? You've seen that picture of the triangle and the light coming through it and the rainbow out the other side, or maybe it's the other way around, the rainbow going in and just the straight. Boy, that's a Freudian slip. The more plain, I should say, light coming out the other side. Essentially, we have all these factors that are shining through a person and then kind of being expressed in that individual. I like to think of that. I like to think of gender and even sexuality that way, because it conveys or moves away from this idea of a binary. So even a continuum or a spectrum indicates that there are sort of two extremes, and that's really not what the scientific evidence bears out when it comes to really much about humans, but certainly for the purposes of this video, certainly not when it comes to sex and gender. And so getting into the science, for more than 100 years, okay, and I think this is something that really kind of I found surprising when I was doing my literature review for my dissertation. For more than 100 years, there has been evidence in the peer-reviewed literature that there is considerable diversity within how people identify and express themselves relative to gender. And there's also considerable diversity in how individuals and groups understand, experience, and express gender through the roles they take on, the expectations placed on them, relations with others, and the complex ways that gender is institutionalized in society. So I think it's also important to note that every major healthcare professional organization in the world at this point has endorsed the affirmation and the normalization of this diversity in gender identity and expression. Nevertheless, of course, as I'm sure you're well aware if you're paying attention to the news at all, transgender and gender diverse identity during the 21st century in the United States specifically, although it's happening worldwide, transgender identity and gender diverse identity has been associated with pervasive patterns of mistreatment and discrimination across social, educational, occupational, legal, and healthcare experiences. There was a national survey conducted in 2015, the results of which were published in 2016. It was called the U.S. Transgender Survey, or USTS. And more than half, or 54% of the nearly 30,000 adult or 18 and over participants from all 50 states, U.S. military bases, and territories around the world reported being verbally harassed for reasons related to their gender identity. So more than half of people around the world have probably experienced some type of verbal harassment related to gender identity. And then nearly a quarter, 24%, of respondents reported being physically attacked, and 13% reported being sexually assaulted because of their gender identity. Nearly a third of respondents, or 30%, reported workplace mistreatment, such as being fired or denied a promotion in relationship to their gender identity. And 17% reported experiencing such severe mistreatment that they left school. 10% of respondents whose gender identity was known to their immediate family reported that family members had acted violently toward them. Transgender and gender diverse people have been shown to be overrepresented in populations associated with negative mental, physical, and social health outcomes, such as those suffering from suicidality and homelessness. So, for example, while the rate for attempted suicide in the United States is about 4.6%, 40% of USTS respondents reported a suicide attempt within their lifetime. Generally, concerning mental health, 39% of USTS respondents reported experiencing serious psychological distress within a year of the survey. That's compared to only 5% of the general US population reported similar experiences during that same time period. Immense suffering among this group of people. And it's also important to note, and this is updated from some of the resources that are available to you in this item. Emerging evidence suggests that there is no pathology similar to same-sex affection orientation. There is no pathology directly associated with gender diversity. In fact, researchers from the University of Washington reported in 2019 that a study of more than 300 transgender children between the ages of 3 and 12. In that study, transgender children strongly identified as members of their current and self-identified group, that is their trans or gender diverse group, and showed gender-typed preferences and behaviors strongly associated with that identity. Transgender children's gender identity and gender type preferences did not differ from the two cisgender control groups. The researchers suggested that early sex assignment and parental rearing based on that sex assignment do not always define how a child identifies or expresses gender, perhaps lending support to earlier theories that gender identity was formed and crystallized during early childhood, and that it appears to develop and crystallize more independently of parental rearing or other environmental factors than it does biological factors. And this finding is consistent with previous and similar research involving cisgender children. So it's sort of the suggestion of emerging research that transgender identity and otherwise gender diverse identity develops around the same time that it does for cisgender identity, which is pretty early in childhood, between around the ages of 3 and 4 years old. So like other disorders we've talked about during this term, this evidence sort of begs the question, where is the disorder? Why is it included in the DSM? Is the disorder with the person dealing with dysphoria, or is the disorder with society that mistreats people with that presentation? Perhaps now is a good time to kind of get into the diagnostic criteria. So gender dysphoria, there are essentially two diagnostic codes in the DSM-5 TR, as there were in the DSM-5 in 2013. You can diagnose a person with gender dysphoria in adolescents and adults, and you can diagnose someone with gender dysphoria in children. Basically, and we'll talk about the criteria for adults and adolescents, and then I will encourage you to pay close attention to the nuances between adult, adolescent type and childhood types of gender dysphoria. So gender dysphoria for adults and adolescents is characterized by marked incongruence or differences between one's internal sense and external expression of gender and their assigned gender, which is at this point considered to be congruent with their assigned sex, with a duration of 6 months or longer, and manifested by at least 2 of the following 6 criteria. So there must be incongruence between gender identity expression and their primary and or secondary sex characteristics. Primary sex characteristics are kind of what we have at birth, right? Our genitalia. And our secondary sex characteristics, I should say genitalia and other reproductive parts like testes, ovaries, uterus, prostate, those types of sort of anatomy. So that's primary characteristics, and secondary sex characteristics are what we develop during puberty. So breasts, our menses, body hair, that type of thing. Those are our examples of our secondary sex characteristics. So the first criteria of the 6 is incongruence between gender identity expression and the primary and or secondary sex characteristics. Secondly, there must be a strong desire to be rid of one's primary and or secondary sex characteristics because of the aforementioned incongruence. A strong desire to be of an alternative gender to the one assigned. A strong desire to be treated as an alternative gender. A strong conviction that one has the typical feelings and reactions of the alternative gender. And there must be clinically significant distress or impairment. So again, 2 of those first 5 things that I read, the incongruence between gender identity and sexual characteristics, strong desire to be rid of one's sexual characteristics, desire to be of an alternative gender, to be treated as the alternative gender, and a strong conviction that one has the typical feelings and reactions of the alternative gender. And these characteristics lead to clinically significant distress or impairment. And we have outlined the extensive impairment and distress that, and we only sort of really scratched the surface. We didn't get into homelessness numbers or things like that. So please do watch the frontline video, but I'm getting a little bit ahead of myself as I'm going through my notes here. So those are the diagnostic criteria. So coming back to sort of the question about why is this even in the DSM? If we know that there's no pathology directly associated with gender dysphoria or sort of gender diversity, similar to no pathology being associated with affectional diversity, homosexuality has been removed. Why have we not removed gender dysphoria? Well, one of the reasons that is used as an argument for keeping it in the DSM is really maybe a implied criticism of our healthcare system. But it's essentially, for better and for worse, gatekeeping. So treatment for gender dysphoria in many ways boils down to the normalization, affirmation, and support of gender expansive identities and the people dealing with them. So basically, if you're working with someone with gender dysphoria, use Rogerian principles, right? Actively listen, show unconditional positive regard, empathic understanding, those types of things. And I'll share with you that there's some more recent research that really drives home the depth of the extent of the impact of support, especially um, for transgender youth when it's parental support. But it doesn't necessarily have to be parental support. It can be any sort of meaningful adult in the person's life, a teacher, a coach, a therapist. So that support uh, often is very helpful. And in addition to that support, treatment for gender dysphoria often, but not always. It's important to note that this is not always true, but it often involves helping a person make a social and or physical, that is a medically supported transition, so that their gender identity and their gender expression and their bodies can be better aligned. This may involve an interest in accessing medical interventions in the form of hormone or surgical treatments to align identity and body. And so in order to access current treatments like gonadotropin releasing hormone agonists, also known as puberty blockers for younger adolescents, cross-sex hormone replacement therapy, such as which is commonly known as HRT. So a person is sort of chromosomally female. They may be taking injectable testosterone. Those of those who are chromosomally male taking injectable or pill form estrogen. So HRT or gender confirming surgery, such as breast removal, breast reconstruction, penectomy, orchiectomy, vaginoplasty. In order to access these things, a person must, whether they are adult or a child, they must currently receive one and sometimes two referral letters from mental health professionals in order to get the surgery and or to have it covered by funding sources such as insurance plans. And so part of this referral process involves accurately diagnosing gender dysphoria and other mental health concerns, including whether or not a person has the cognitive intellectual capacity to give informed consent for such a treatment, and whether or not any mental health concerns other than gender dysphoria, such as depression or anxiety, are present or well managed. So this cognitive capability, as well as the diagnosis of other mental health concerns, really is within the scope of practice for mental health professionals. More often than not, even as professional counselors, even though we're not necessarily focusing our practice on cognitive and intellectual assessments, you can often tell if a person is capable of making an informed decision just by talking with them. Can they provide a well-developed sort of description of their history, their gender identity, and their rationale for seeking medically supported treatments? Sometimes there may be evidence that a referral for a more in-depth assessment is necessary, but that is actually more often than not necessary. So one of the benefits of having it in the DSM is to facilitate this process. The downside is that this process is even sort of required. I think there's a strong argument to be made that a person should be able to access healthcare based on the evidence we have now that includes medically supported transitioning. But we're still in a state of sort of medical history in which medical necessity is required for certain procedures to be conducted. And we as mental health professionals have a role to play in facilitating that process. And of course, one of the more obvious downsides to having it in the DSM is that it is stigmatized as disorder in some way, shape, or form. People see it as pathological. But as I've repeated over and over again, the emerging evidence confirms evidence from more than 100 years or over more than 100 years that suggests that it is in fact not pathological. It's part of a normative human experience of diversity. So please do, we're not doing a case example for this disorder because I think it's better personalized by the frontline video. It's about 90 minutes long, but does a lovely job of personalizing the condition from the individual, family, and societal levels. I also recommend that if you have access to Disney Plus or Nat Geo Plus, check out the documentary that was released a couple years after the Frontline video. I think the Frontline documentary, Growing Up Trans, was released in 2015. The documentary Gender Revolution and its accompanying National Geographic magazine articles were released in 2017 and provides a little bit of a wider scope of personalization. There are children through adults that Gender Revolution discusses, whereas Growing Up Trans really just kind of focuses on young people. I've also included, like I said, I mentioned I'm going to include my dissertation, but it's really long. Now, not all of it is super long. You don't have to like read the references section or the appendices, but you might find not only the literature review, sort of a deep dive into some of the key issues related to gender dysphoria and the way that it impacts children and families, but also, I don't know, maybe I'm biased because I did the study, but just the deeply moving responses from the parents that I interviewed about their decision-making process. Now, I've included the full dissertation form. I've also included the much abbreviated form that was published in the journal, The Professional Counselor, which is the National Board of Certified Counselors journal. That was published at the end of 2021. So I've included that if you would like an abridged version. But again, I think you'll find these things interesting and would be very interested to discuss this class or this disorder with you further in the discussion board. Yeah, I hope that if you have not been interested in this type of work before, that maybe you're a little bit more interested now than you have been in the past. This is a group of people who certainly needs improvements to access to quality care, especially quality affirming and normalizing care. And I would love to support you in your development of those skills. Until then, hope you have a wonderful rest of your day, and look forward to seeing you in the next module. Thanks.